Prescribed Drugs and Traumatic Brain Injury, Part 2, presented by Dr. Gregory Oshanik.
So, with neuropharm, the studies generally are based on other populations. Okay? So when we're looking at the neuropharm in brain injury, so if you're looking at the use of antidepressants, if you're looking at the use of medicines for cognition, stimulants, any of those things, they're all based on other populations. There is only one medication, there's only one medication that is specifically approved by the FDA for use in traumatic brain injury when you've got pseudobulbar affect or pathologic laughing and crying. All the other ones, drug companies, when they develop a medication, they've invested billions of dollars in these. And so they want the purest, simplest group possible to study so that they can then get it to market. Okay? So they're not going to pick something as homogeneous, or heterogeneous, excuse me, as traumatic brain injury. They're going to pick depression. They're going to pick ADD in kids. They're going to pick, schizophrenia, if that's really uniform. So any of the medicines that we use generally are called off-label. Off-label means that it was not what the FDA approved it for in the original application. It does not mean that it's illegal. Physicians can prescribe medications off-label using their clinical judgment, understanding what the mechanism of action is. Great example is a blood pressure medicine called Inderol, propranolol, first beta blocker developed. Used for blood pressure, now it's used for everything from migraine prevention to panic episodes, a whole host of things that it can be used for, Off-label. Now, the problem with the off-label comes when we're trying to get reimbursed. Real interesting phenomenon. If I prescribe a medication that is brand name, does not come in generic, good example would be Nuvigil, which I used for fatigue after traumatic brain injury. If I use Nuvigil and a person shows a response and I then send it to the insurance company and the good old insurance company comes back and says, that's off-label. That's experimental. We're not going to pay for it. Interestingly, what they'll recommend is, why don't you use methylphenidate or an amphetamine or something of that nature to treat the fatigue? Guess what? That's off-label too, but they're generic and they're cheap. The only time that card gets played in terms of off-label is because of expense issues. All right? Doesn't mean it's wrong. Does not mean it's wrong for a physician to prescribe it. The other difficulty is, though, about 20% of my patients have no resources. And so probably 1/2 of an FTE of one of my staff members is spent getting patients signed into patient assistance programs to get medications. Can't use TBI as the reason, though. Okay, if we're getting them on Cymbalta, we got to talk about depression. If we're putting them on Exelon, we got to talk about dementia. It's wordsmithing, okay? Is it a gray zone? Yeah, it is. But the issue is that they are not, the pharmaceutical companies are not allowed to give medications away to patients knowing that it's being used off-label. All right? So many times what we do is we're looking at what we would call a comorbid or premorbid condition. Even if it was really small, somebody just had a little bit of dysphoria, a little bit of adjustment reaction, okay? If I can parlay that into a depression or use those terms so that I can get them whatever the brand name medication is, that's somewhat of a deal with the devil. Questions about this? Yes, ma'am.
Can you explain those terms, comorbid and premorbid?
Comorbid means you've got fleas and ticks. So Yeah, so it means that, not only do you have a traumatic brain injury, but unfortunately, from a genetic standpoint, you've got a family history of bipolar. And with the damage to the frontal lobes that keeps you from being able to inhibit and to find other ways of dealing with things, all of a sudden the bipolar disorder becomes more clinically significant. So that is comorbid. That's fleas and ticks. PTSD and TBI together, fleas and ticks. Premorbid is before the injury. Okay? And these become, in litigation situations, workers' comp situations, that kind of stuff, these become really kind of crazy making, because then it becomes about who's going to pay for it, not what do we do to get the person better. So, now, my mom told me when I was growing up that the 4 things that you needed to do to be healthy: you needed to get a good restoring night's sleep, you needed to get exercise every day, you needed to stay hydrated, and you needed to eat nutritiously. Those 4 things are no less critical in individuals with neurologic damage. In fact, they're more critical. Because unless you've got the foundation of those things and pain management, you are not going to be able to achieve the kinds of things you want to in terms of medications. All right? For example, sleep. With traumatic brain injury, we lose the reserve in terms of being able to tolerate insomnia. Anybody who's had a sick child, who's been up all night with that kid, the next day they know you're not kind of working on all eight cylinders. In fact, that process is so critical that we don't let interns and residents do what we did in my day, which is work for 36 hours, go home for 12, work for 36, go home for 12, because when they tested medical students and residents in the afternoon after being up all night on attention and concentration, memory, and speed of information processing, they tested at the same level of impairment as individuals who did those tests when they were drunk. Okay? Attention and concentration, memory, speed of processing. Those 3 things sounds familiar? It's exactly the same 3 things that you see neurocognitively after traumatic brain injury. So if you've got somebody who is having a little bit of sleep apnea, and sleep apnea isn't just me, isn't just guys that played sports and big necks. It's thin 15-year-old girls can have sleep apnea based on the size of their chin and the size of their mandible. If you have mild sleep apnea that you can compensate for pre-injury, after the injury, you lose that ability. And it needs to be addressed. People need to be pursued in terms of sleep studies. If you wake up in the morning and you're still tired, it's either you're not sleeping enough or you're not getting restorative sleep. Okay? Even more critical after TBI. You don't fill your gas tank at night. After TBI, you don't get the same mileage. So you start out the day with a half tank. So issue is getting adequate sleep and doing whatever you need to make sure of that in terms of looking at studies. Sometimes it's having to do CPAP. Sometimes it's having to use supplemental oxygen. Trazodone is one of those off-label medications that helps with initiation of sleep, not habit forming. You want to stay away from things that increase GABA because that screws up your sleep patterns as well. Then the other thing that happens, if you get any stomach acid, any gorge, that refluxes into your esophagus, there is a disorder called sleep-related laryngospasm. And you get an involuntary reflexive closure of your windpipe, so you don't spill acid and burn your lungs. So Those are individuals that then need to be on Nexiums or Protonics or Previcids or something of that nature, and or you raise the head of the bed 6 inches. Okay, so gravity keeps the flow. You know? So that's the other reason that could be happening. Now, you could also be having nocturnal seizures. You could also be having a whole host of things that are preventing you from getting into deeper stages of sleep, which is why 99%, 95% of my patients get sleep studies. Studies have shown about 80% of people after TBI have disrupted sleep architecture. So instead of stage 1, 2, 3, 4 in dreaming sleep, okay, that normally takes 90 minutes. You need 3 or 4 of those episodes per night to feel rested. Okay? And so you will get disruption in terms of 3 and 4. You can get disruption in terms of dreaming using things like, you know, clonazepam to some degree, Valium, Xanax. Those things screw up sleep cycles. Even most of the sleep medications screw up sleep cycles. Interestingly, there's one that you'll see later called mirtazapine that does not. Okay. Nutrition. Again, glucose and oxygen are the 2 things your brain needs. High peaks, lows, if you're not stable, you're not going to be able to manage it. How many folks, well, let me personalize it. In my office, one of the staff is charged with making sure that lunch is brought to me. I mean, I work through lunch, I'm always behind. You know, we talk about, you know, yes, your appointment was at 1 o'clock, but I didn't say whether it was East Coast time, Central time, Pacific time. Okay? So, but if I don't eat, I get nasty. I get irritable. Okay? Now, same thing happens in terms of irritability and increased agitation for people who lose that ability to inhibit because of frontal lobe changes. So that's why behavior before mealtime can be such a disaster. Or why somebody eats a candy bar and they're all just John Sweetie Goodpants, and then the crash happens. And then it all goes out the door. So nutrition is critical. 70 to 80% of our brain is water. By the time we know that we're thirsty, we're already dehydrated. You need to be drinking, and my patients get handouts on all this, you need to be drinking so that you're going to the bathroom every 3 to 4 hours. Okay? Now that can make for some caregiver difficulties, but again, the risk of dehydration is substantial. Now, you got to stay away from Cokes and coffee and all that stuff to do that, because caffeine is a diuretic, makes you pee more, and you'll get more dehydrated. So you've got to be careful. Not that we can't have coffee in the morning, God forbid. Now, exercise. The group at UCLA, David Hovda, who is a professor of neurosurgery there in neuroscience, who is on the board of BIAA, David and his group have looked at the role of exercise in terms of recovery following traumatic brain injury. And first they looked at it in animals, then they looked at it in critters. And clearly what is shown is that individuals who are getting 30 to 60 minutes per day of some sort of cardiovascular activity, it basically enhances recovery. Maybe it does it because of catecholamines, maybe it does it because of endorphins, a whole bunch of different theories. But the bottom line is it improves recovery. It also improves fatigue. Okay? And so, and the exercise doesn't mean that you've got to go to the gym and be, you know, on the treadmill. It means that you got to be up and walking and moving. Okay? Housework, going up and down stairs, going down to get the mail at the mailbox at the end of the driveway. All of those kinds of things count in terms of exercise. Pain is critical because if you're in pain, pain disrupts sleep. In part of my career, did a lot of work in terms of working with cardiovascular surgeons and individuals who had just had their chests cracked. Okay? Very painful. If we could get people sleeping at night, give them enough pain medicine at night that they would get a good night's sleep, the amount of pain medicine that they needed during the day dropped dramatically. So it tied back into the sleep issue. All right? So pain management becomes critical in terms of individuals, especially with polytrauma. Pain management may be something as simple as using a sculpted foam pillow, okay? The kind that cradles your head. If you wake up in the morning with headaches, could be sleep apnea, because that'll give you morning headaches. But more typically, it is because of cervicogenic pain, neck-triggered pain. And so if you are flexing or extending your neck as you're sleeping, that's going to put more strain on it. If you can cradle that so that it stays, you'll have less difficulty in terms of morning headache. That combined with maybe the use of some anti-spasmodics. So pain becomes critical. So these 5 things have to be done before I look at what medicines do we need. Okay? And these 5 things also need to be done before the individual is going to be able to do diddly squat in rehab. If you're hurting, if you're tired, if you're dehydrated and all that, you are not having the optimal environment. Rehabilitation, in my mind, is the same process of brain development and growth as kids in school. You are learning or relearning things because of damage, as we heard earlier. And so just like there's tremendous information about Head Start programs, kids eating breakfast, all of those things, and getting a good night's sleep to make sure they are able to be tip-top in terms of learning and acquiring new information, no less important in terms of rehab. And if somebody is stalling, if they hit a, quote, plateau, whatever that is, go back and look at these 5 things. I'll bet you anything that there's one of these or several of these that haven't been attended to. And so you look at those from a hormonal standpoint. You look at the other 3 hormone systems that are commonly injured after traumatic brain injury, mild, moderate, or severe, are what are called anterior pituitary hormones. The anterior pituitary hormones are thyroid, growth hormone, and either estrogen or testosterone. Okay? Deficiencies of any of those will create fatigue, will create slowed thinking, and will create depression. Okay? The one that, when women who have head injuries then become amenorrheic and skip a period or several, it's because there's a pituitary abnormality. Most of the time it goes back, but that indicates that the vulnerability was there from the get-go. So it's important to look at those 3 hormone systems. It's called neuroendocrine disorder. The Department of Defense is very much involved in looking at that for men and women that aren't getting better. And interestingly, the most common of those is a growth hormone deficiency. Okay? After we reach our adult height, growth hormone is mood stabilizing, is fatigue stabilizing, and assists in cognitive function. So if your growth hormone is low, you will have difficulty. Guess what? Growth hormone is brand name. Insurance companies don't like paying for it because it's a daily injection and is $4,000 to $10,000 a month. So here are the major classes of agents for brain injury, okay? And I'm going to just hit each slide and a couple of high points on each. So anti-seizure medicines, anticonvulsants, here's all of them listed here. Probably the ones that are more familiar now will be Dilantin, Depakote, Lamictal, Keppra, and probably Lyrica for most folks. They're used for post-traumatic seizures. Okay? Just because you've had an just because you do not have a seizure early on does not mean you cannot have a seizure later on. Even with mild traumatic brain injury, no loss of consciousness, population studies show that it doubles your risk of seizures over the course of your lifetime. Okay? Gets back to that hemosiderin bugger we were talking about earlier. There's a disorder called epilepsy spectrum disorder. These are partial seizures, funny smells, funny tastes, creepy crawlies, feeling like there's cobwebs on you, goosebumps only on one arm or one leg. What's called square wave depression, cooking along and everything's fine. All of a sudden, boom, bottom falls out, and boom, and all of a sudden you're fine. Or square wave anxiety, same kinds of things. Waking up in the middle of the night, outside of menopause, when you are sweating, okay, typically associated with goosebumps. These are not things that'll show up on EEGs because they're too deep. They're more temporal lobe related, but these are things that will respond to anticonvulsants. Post-traumatic headaches. A lot of them, if somebody has, quote, psychotic symptoms, psychotic just means not based in reality. There's not a stimulus out there for that hallucination, okay? Auditory hallucinations is more of a schizophrenia type of issue. Visual hallucinations, olfactory hallucinations, gustatory hallucinations, the whoops, lost my stomach feeling, those kinds of things are also hallucinations, but they are from organic causes. They are from irritable areas in the brain. So I just saw a sad situation earlier this week. Kid had a sports-related concussion and was out for like 6 months, out of play, et cetera, for 6 months, not unconscious. Finally gets back to school, and he starts having, quote, hallucinations. He was treated with an antipsychotic, risperidone, got agitated and restless, ran in front of a truck because he was trying to get away from whatever it was that he thought was pursuing him. Okay? This kid was no more schizophrenic than the man in the moon. This kid had been misdiagnosed because he was having seizures that were showing up as visions and creepy crawlies and those kind of things, deja vu experiences nobody understood. Okay, antispasticity agents, basically, these are things that are used to decrease spasm, okay? The problem with many of these, or the caution with many of these, is they work by increasing GABA, okay? So they will generally create some degree of fatigue, which is why you want to use them primarily at night, okay? So that you can get a twofer out of it in terms of improving sleep as well as improving, decreasing kind of morning headache. Antidepressants. So antidepressants, basically the old guys were the tricyclics and the MAO inhibitors, okay? New guys are things like the SSRIs, Zoloft, Prozac, Effexor, which is a combined serotonin and norepinephrine, Cymbalta, Pristiq. Remeron mirtazapine is the one that really does a good job in terms of sleep. In fact, in Europe, its primary marketing is as a sleep agent because it normalizes sleep architecture. Little mention here, when anybody is on an anticonvulsant or an antidepressant, they will have a problem with folic acid. They will utilize more folic acid. 70% of us don't have both steps enzyme-wise to convert dietary folate into the folic acid that can get into our brains. Okay? Normally that's not a big deal unless your body is under stress. So if somebody is on antidepressants or an anti-seizure medicine, then using a supplemental folic acid that's already been processed, tetrahydrofolate, is useful in terms of not only improving the depression, but also improving seizure control, improving agitation, mood, things of that nature. Anti-anxiety agents, the benzodiazepines, the good old Xanax and Mother's Little Helper Valium. Anybody old enough to remember that song? Good, thank God. At any rate, these all increase GABA, okay? So part of the difficulty is that it's suppressing the system. Sometimes you've got to, okay? When somebody is having a seizure, somebody's, you use Valium or you use IV Ativan to lyse the seizure. Or if somebody's having significant spasticity issues. Initial insomnia, you can use it short term, but it's not something you want to stick with. One of the problems with benzodiazepines, especially short acting, anybody ever have their wisdom teeth taken out or endoscopy or anything of that nature? Guess what? You weren't really asleep. They gave you a short-acting benzodiazepine. Usually it's Versed or midazolam. What that does is it separates your RAM from your hard drive. So you are saying all sorts of crap. You just don't remember. Okay? So that is even more critical in terms of patients that we deal with who have problems with their RAM being separated from their hard drive because of their traumatic brain injury. So you've got to watch in terms of that increased vulnerability. Buspirone is a non-benzodiazepine anti-anxiety agent, kind of changes the color of the stress, so it decreases the irritability, decreases the impact of it. Great study at Duke by one of my mentors showed that when they gave Buspar to a group of med school graduates and they followed them over time and they gave it to someone who they didn't give the medication to, the guys that were on Buspar had fewer incidents of cardiovascular problems and heart attacks after about a 30-year period. So stimulants, they all act in one way or another to increase norepinephrine or dopamine, okay? The ones from here up work by squeezing out neurotransmitter from the vesicle. So they work immediately. So the Adderalls and the Ritalins work immediately. They don't last that long. They last anywhere from 3 to 12 hours. Okay? They also, because they work immediately, are highly prone to addiction and abusing because you get an immediate response. Okay? What are they for?
She's on Adderall.
Yeah, they're for attention and concentration. They're for fatigue. They are also, there's a number of studies with methylphenidate that show that it enhances learning in terms of recovery. Great study done in acute rehab by folks at Moss, John White and colleagues. So the more you can do to increase, to a limit, dopamine and norepinephrine activity acutely, the better learning you get. Okay. They're used for attention concentration, fatigue, narcolepsy or post-traumatic sleep disorder, and apathy or amotivation. The cognitive enhancers, again, we are looking at using these generally off-label, but in terms of dementia, once you hit age 65, each decade, your likelihood of developing Alzheimer's doubles, roughly. So my simplistic thinking is, if you have a major withdrawal from your bank account earlier in life, okay, then you've really moved your chronology earlier. So you may need medications in your 40s, 50s, early 60s that you might not otherwise need to prevent the decline until your late 60s, early 70s, 80s. Okay. Omega-3 fatty acids are, again, one of those building blocks, basic building blocks. Thank you, Department of Defense. 1,000 milligrams twice a day. Buy the cheapest ones you can. Put them in the freezer. literally, because then they're solid, you don't get the fishy aftertaste. The biggest problem then is remembering they're in the freezer to take them. But antipsychotics block dopamine receptors in the brain. Generally, that's how they work. Abilify does a little bit different, but does have dopamine interaction and serotonin interaction. But the rest of these all work by blocking dopamine activity. I'm going to leave you with one study that came out in 1980 in terms of the effect of medications that block dopamine after brain injury. A guy named Dennis Feeney took a group of volunteer mice. Okay. Put them into 4 different groups. He basically removed half of their brain, the motor area, and he went to see how long did it take them to relearn a balance kind of activity. He then gave them haloperidol, Haldol, or he gave them amphetamine, or he gave them haloperidol and amphetamine, or salt water, and then saw which ones relearned the balance paradigm fastest. Who relearned it fastest? Amphetamine. Increasing dopamine and norepinephrine activity improved learning. Who learned second fastest? Salt water. The ones who had any type of dopamine blockade, Haldol with amphetamine or Haldol alone, haloperidol alone, were the slowest because it inhibited learning. So the use of these medications has to be done thoughtfully. Doesn't mean that you can't use it, okay? But it's got to be done thoughtfully and got to be done when other options have been tried that have not worked. Thank you very much.
To learn more about resources and information provided by our experts, call Brain Injury Association of Florida's helpline at 800-992-3442.